have Dr. Kivala with us today, the past president of American College of Emergency Physicians with us. What did you think of the conference so far, and do you have any ideas and comments on it?
Well, this has been a wonderful conference. This is my second year here, and I thought last year was fantastic, but it's even better this year. I find the depth of all the lectures is important and understanding for me, and I really see a tremendous advance for how Turkey and the rest of the world is practicing emergency medicine.
Thank you very much. And do you have any ideas or visions for the future of collaboration between the international societies and groups of emergency physicians?
Yeah, I think that there's a lot of opportunity for us all to collaborate. I think we all are facing the exact same challenges. You know, yesterday we all talked about the future, and it's important to look not where we're at right now, but where the future will be in 5, 10, 15 years. I think one of the first talks about violence is important. It's not just a problem in the United States, it's a problem in Turkey, it's a problem in Europe, it's a problem in Australia, it's a problem in Africa. So I think this is something that we can start working on, finding solutions together. Other issues like disaster management, terrorism, overcrowding, psychiatric patients are a challenge for doctors everywhere. And this is something that I think we can work on together to find solutions so that we're not all finding independent solutions or running into the same continued challenges.
Absolutely, I agree. Thank you. It's, as always, been a pleasure having you here. Thank you for coming.
Oh, it's in my honor.
So I have Dr. Roger Dickerson, doctor in emergency medicine from Cape Town, who hates titles and is with us in Antalya for the great conference of EPAD. How do you like the conference so far?
Well, the conference has been amazing, but to be honest, it always is. Prof. Chanda always puts together such an amazing conference. This is my third year in Antalya for the EPAD conference, and it's absolutely amazing to be here once again. The variety of speakers, the variety of topics that are covered, and purely the number of streams, the amount of information that is being shared at this conference is just amazing.
And you had a great talk just a second ago, so my last question would be, is adrenaline really falling from grace?
So, firstly, thank you for your kind words. That's, I do try. With regards to adrenaline, I think the jury is out. But what I think is becoming true is that it's not the sacred cow that we always thought it was, that we used to throw adrenaline at everything because it was the right thing to do. I think what the recent publications have shown is that we need to focus on what patients need, and that may change from time to time and from condition to condition within the same patient, let alone from patient to patient.
Okay, so for now, that need is to remain alive.
So my answer is, do I still use adrenaline? Yes. Am I starting to think about whether I should be using it? Absolutely yes.
Perfect answer. Thank you.
Awesome. Thank you so much.
Thank you. So today we're on the second day of the Congress, and I have Professor Dr. Abdallah Belou, the past president of USAM, professionally interested in quality and safety in emergency medicine with us. He just gave a great talk about global network and quality and safety and how to increase it in the emergency department. So can you give some small tips on how can we make it better and how these conferences help us get things going?
Thank you very much. I'm very happy to be here in Turkey, and I would like to thank the organizer, particularly Professor Bashar Kanda. Yes, quality and safety is the cornerstone of the healthcare system, and we need to implement processes in our emergency department in a way that will help us to improve the quality and the safety of the care in the emergency department. I think conferences can help us to do that, because we can gather our knowledge, our expertise together, and then try to see how we can compare our data, and then see if we can implement different processes to improve the quality of care. I do believe that conferences is very important, and this conference is fantastic, and I'm very happy to be here, and I feel that the Turkish emergency physician wants to improve the quality and safety in emergency department.
Thank you for being here and thank you for sharing your time with us.
Thank you very much. I appreciate it.
Today we are with Lucy Schiffelbein, and first of all, would you like to introduce yourself to us?
Certainly. So I'm Lucy Schiffelbein and I'm from the New Zealand National Poison Centre, and I'm also from the Toxins Poisons Information Database.
Okay, what do you think about this Congress?
It's fantastic, just having the opportunity to be able to participate in a Congress which helps strengthen the capacity in the region is just a wonderful opportunity.
Okay, thank you.
Welcome to Istanbul. Please introduce yourself and what do you think about Congress?
It's nice to be here. My name's Hannah. I'm working with Integral Global, and I'm happy to be at the conference. It's going very well. Lots of really important information.
How do you say about Turkey foods or Istanbul?
Well, I like sweets, and
Sweets.
so the Turkish sweets are faring me well.
Okay.
Yeah, I'm enjoying the food. It's wonderful.
Thank you very much.
Yeah.
Welcome again.
Thank you.
Hello, my name is Nabil Ahmed. I'm the director for Integral Global, one of the participants for this conference, and this is my 5th time in Istanbul, and I always like coming to Istanbul. It's a beautiful
love
city.
Istanbul.
Yes, I love Istanbul. I love the food, especially the kebab.
Thanks. We love it too.
Yeah.
Welcome again.
Thank you very much.
Hi, I'm Mazda Shirazi. I'm the medical director of Arizona Poison and Drug Information Center. This is my 2nd time being involved with your physician group, the emergency physician group. Last time I was in Trabzon. And it's actually lovely to be in Istanbul. And I'm partly Turk and partly Persian, so I always like to come back to the region that my heritage is
We are
from.
waiting for you every time. Thank you very much.
Okay.
Okay, Mr. Charles McKay, welcome to Turkey. Can you introduce yourself to us?
Sure. Charles McKay, I'm a medical toxicologist, physician toxicologist in Connecticut, the eastern part of the United States, and immediate past president of the American College of Medical Toxicology. It's a national organization of physician toxicologists.
Thank you very much for welcome to you also again. Did you like the program of the conference? How do you find our preparation? Can you make some comments for us?
Oh, sure. No, it's been very enjoyable thus far. It's always amazing to see how a group of people will come together from different areas to try and provide some information and training across common areas of concern. And certainly EPAT and Menatox here, the board and all of the participants have been doing a great job running really 3 simultaneous tracks today and 2 tracks in the next couple of days. It's always a challenge, but it seems to be going very well.
Thank you very much. 9. Menatox Klinik Toksikoloji Konferansı'nda İstanbul'da Başar hocamızla birlikteyiz. Hocam yurt dışından, Amerika'dan, dünyanın birçok yerinden 70 tane yabancı katılımlıyla İngilizce ana dilinde bir konferans düzenliyorsunuz. Ne hissediyorsunuz? Nasıl gidiyor konferans? Katılımcılar katılımdan memnun musunuz? Düşüncelerinizi alalım.
Yani bu Menatox'a ev sahipliği yapmamız gerçekten bizim için çok önemli bir dönüm noktalarından biri. Çünkü toksikoloji ülkemizde şu anda emekleme dönemini geçip yavaş yavaş yürümeye başlayacak bir branş gibi görünüyor. Şu anda yaptığımız bu kongrede aslında ülkemizdeki en büyük uluslararası kongrelerden bir tanesi. Yani 70 tane yabancı konuşmacının sizin de bahsettiğiniz gibi ki bunların birçoğu okyanus ötesinden geliyor. Ve ülkelerinde de dünyada da saygın isimler. Bunları bir araya getirmek, İstanbul'da buluşturmak ve İstanbul'u toksikolojinin bir gündemi olarak oluşturmak bizim için çok önemli adımlar. Gerçekten bu yüzden hem mutluyuz hem gururluyuz. Ama bir taraftan da bu konuda gerçekten bütün asistanlarımızın, bütün uzmanlarımızın daha çok ilgi göstermesini, toksikolojiyi takip etmesini bekliyoruz. Çünkü toksikoloji acil tıbbın ana branşlarından biri olmaya gidiyor. Ana branş derken yani ana altyapılarından biri olacak. Çünkü hastalar zaten toksikoloji hastaları öncelikle acil servislere başvuruyorlar. Onların tanısı ve tedavileri de acil serviste devam ediyor. Bu yüzden acil tıp konusunda toksikoloji giderek ilerleyen süreçte daha önemli bir pozisyona gelecek. Yani toksikoloji acil tıbbın çok önemli bir bölümü olacak. Burada baktığımızda Amerika'dan, Avrupa'dan ve sadece bu coğrafyadan değil, aynı zamanda mesela Uzak Doğu'dan gelen misafirlerimiz var. Bunların da çok ciddi çalışmaları var. Bunlar da gönlünü toksikolojiye vermiş çok önemli bilim adamları. Çok güzel noktalara vurgular yapıyorlar. İnteraktif çok iyi geçiyor. Yani bu konuda duyarlılığı artırmak, farkındalığı artırmak için önemli bir mihenk taşı olacak diye düşünüyorum. Acil tıp açısından da şöyle düşünmemiz lazım. Acil tıp açısından. Yıllardır beklediğimiz adımlar bunlar. Çünkü birçok acil tıpçı aynı zamanda üst ihtisas yapmak istiyor. Üst ihtisasın en önemli maddelerinden biri toksikoloji. Bununla ilgili bazı gelişmeler oldu dönem içinde. Bu daha ileriye taşınacak. Öyle görünüyor.
Çok teşekkür ediyoruz hocam. Ülkemizde böyle bir konferans düzenlediğiniz için.
Thank you very much, Canlı, for this very nice invitation. It's a privilege for me to be the first speaker of this huge congress, and I think that what you did in this session is to address the importance of invasive technology as a new opportunity to increase the power of emergency medicine worldwide. I really am happy to address this topic, and this topic is coming as the need, and we will see during my presentation, to work together. Not only emergency physicians, but radiologists, interventional cardiologists, to produce more evidence and publications, as we did into the great network, worldwide academic research organization that is with WASM worldwide try to increase the powerful of publication in our group. And I really appreciate that you put in the backs many journals, because this is the future of emergency medicine, to produce evidence. So let's go now and see, after my disclosure, what are really the need for technology support after clinical evaluation. Before starting my talk, let me tell you that no technology can support a bad emergency physician, because the best technology emergency physician has is his holistic opportunity to visit the patients and make clinical decisions. By the way, in the last 25 years, we saw an important increase in quality of laboratory testing, especially biomarkers in acute disease and point-of-care biomarkers, but also technology of imaging. So laboratory testing and imaging are going to be the big revolutions in our job to increase the quality of our medical effort and most importantly, increase patients' outcome. When you talk about imaging, for sure you know that ultrasound are totally changing our ability. Every emergency physician now are able to perform ultrasound, and I'm very proud that we were the people that teach cardiology on how to use chest ultrasound to detect many diseases they were not able to do. But nevertheless, besides the ultrasound that are growing impact, there are other technologies such as point of care, looking at the computer-assisted imaging, but last but not least, the angiography. Angiography is really important, and I think it's something that can really improve our knowledge and also quality of health delivery system. But of course, the issue here that angiography need a cath lab or let's say radiology interventional box that should be as much as possible close to the emergency room. So this is the first example. 250 years ago in my regional city, Naples, these researchers put some substance into the vessels of humans. And these skeletons are still there in Naples, one man and one woman. And you see, he put these injections, but unfortunately, patients died. But luckily now, we have many different radio contrast possibilities that are able, thanks to invasive medical imaging technology, to use this iodinated contrast material to visualize the lumen of blood vessels. And this is very important because thanks to the angiography, now we can have very clear opportunity to see the brain, the neck, the aorta, the chest, the gastrointestinal tract, and so on. But what is important, not to abuse the technology, but to make the right decision. First of all, now blood vessels should be evaluated also with non-invasive technologies such as ultrasound, echo Doppler, TC scan, and magnetic resonance imaging. Nevertheless, although these new non-invasive technologies are going to be every day much more precise, we still need angiography, catheter-based, in the cases you need immediately decision-making to transfer the patient to surgeon, or last but not least, to have access to intervention radiology procedures that can impact the length of stay of our patients in the emergency room, and also to reduce the length of stay in the hospital and the costs related. So this is the way you have to think about how angiography can really increase our emergency department job every day. So I have one question for all of you. How many of you today have an angiography service available 24 hours, 7 days in your emergency department? Please raise your hand. Not so bad, 15%. Okay, let's see if the other 85% could be convinced at the end of my talk to try to insist to have an angiography box in their emergency department. So, and I think this is coming to the fact there are so many acute diseases that are linked here, such as acute myocardial infarction, multiple pulmonary embolism, trauma, that can benefit having an angiography area into the emergency department. First of all, let me address my special topic, acute coronary syndrome. We know that time is myocardium, so you really want to start as soon as possible in the emergency department to reopening the vessels in the case of MI. These recently published 2019 guidelines on how and when to perform angiography in acute coronary syndrome is very clear that in the case of elevated ST myocardial infarction that is within 12 hours, you should do evidence 1A, in all these cases, a PTCA. And then that is a delay opportunity, still evidence 1A, if you have no cath lab available, that you can do fibrinolysis. So in any way, you are going to perform in many patients as soon as possible angiography, coronary angiography, and then opening the vessels. This is a cartoon that I would like to take in mind, but I'm sure everyone in the audience is aware. In the case that you are able to make EKG in 10 minutes, and you are going to refer an hospital where the cath lab is not available, you have two choices. If you are the STEMI, in between 120 minutes, in that case, you can refer for 90 minutes, transfer the patients. Alternatively, if you have 2 hours that the STEMI is started, you can start fibrinolysis there, and then you can reperform in 10 minutes, transferring the patients. But if you have the cath lab, angiography, and the coronary PTCA available, you should do this in less than the 60 minutes. I think it's very important to save as much as possible lives in acute coronary syndrome in our patients. What about if I have a patient with not ST myocardial infarction elevation? In this case, there is the opportunity, if the patient is very high risk, also to go for invasive procedures if the patient is hemodynamic instability, if there is life-threatening arrhythmias, and also acute heart failure. So still in these patients, you can do PTCA within 2 hours. So something that you could do there, because you are going to save and increase the number of lives in the emergency department. So let's move now. Another important frequent reason for patients coming, pulmonary embolism. In this consensus statement for multidisciplinary physicians, it's very clear that in the case there is a big embolus that is very close, massive embolus, very close to the original pulmonary artery, you should do catheter thrombolysis and removal of the thrombus. So it is very important also to consider in patients presented with the syncope, massive TC scan, pulmonary embolism, to do angiography and remove the clot. Now, what about the need also to look at the aorta during patients coming in? I'm sure experience with patients coming with chest pain, you are looking for acute myocardial infarction, the patient can have aortic dissection. So aortic dissection is really a situation where the emergency physician can have the need to make aortoangiography. What the guidelines say that the most risk is the ascendant aneurysm and the dissection, where the patient should be immediately treated with the beta blockers. All these patients should have beta blockers and then transfer immediately to cardiosurgeon in order to make a decision. So aortic dissection is another really important situation when you need angiography to perform as soon as possible. Now, I'm sure also in your daily practice experience, you are managing with the patients coming in with acutely cool, painful leg, and in this case, you really are going to clinical put a suspicion of acute limb ischemia. In this case, you can perform a Doppler that is mandatory, and in the case of Doppler, you can have 3 possibilities. Assuming that you have no artery in the, let's say, pink area, sound, no vein sound, don't waste time. Ask the surgeon to make amputation on the leg. On the other side, in the green area of this cartoon, if you have a presence of audible artery and veins, you are going to do angiography because you want opening the vessels that bring blood to the limb. So I think it's very important also in the acute limb ischemia after the clinical judgment and also non-invasive assessment to go for an angiography. Now, another important issue where the angiography is going to be increased, the role is a stroke, both ischemic and hemorrhagic stroke. In ischemic stroke, in the case of these 6 possibilities, pre-stroke MRS score between 0 to 1, causative occlusion of the internal carotid artery of MCA segment 1, age greater than 18 years, NAIHSS score greater than 6, aspect greater than 6, treatment of removal the occlusion of the artery should be done after angiography, but in the case of the symptoms are greater than 6 hours, and you cannot do thrombolysis. But what is important, this leads to the need, like the recommendation, guidelines 2018 are going to put out the importance of a multidisciplinary team that is my auspicious in this conference. Opening the ceremony, I think is a very good opportunity for me to tell that we have to work all together in order to improve our skills and patients' treatment. And also it is important that angiography should be there in the case of ischemic stroke. And also it is important that you want to monitoring. So our job is not only to start appropriate treatment, but to monitoring patients' outcome and publications on the results. What about hemorrhagic stroke? There is no doubt there are a lot of situations where you can use clipping or culling of the hemorrhagic site after brain angiography, and then you can save the patients, especially if he has hemorrhage due to cerebral aneurysm. So it is very evident that so far we addressed the important possibility to check in the case of acute coronary syndrome, acute aortic disease, and acute stroke, the possibility to use angiography. Now, what about trauma? There is no doubt that looking at a lot of bleeding that are going to be not able to stop because of what you're doing with the medical treatment, you should need an angiography. In this case, what is important as an example of the very severe trauma is liver trauma. In the liver trauma, you should consider two classifications. AAST, liver trauma classification, but also when you put together, let's say, the injury type, the grade, and injury description, you should also put one important, very, very important evaluation, the hemodynamic instability. So I would like to emphasize this important clinical judgment of hemodynamic instability, because if hemodynamic instability is present in the case of a liver trauma, you can go a very severe lesion to WHS, ESIV, and go to operating room immediately after an angiography. So there is no doubt that also in the case of liver trauma, you can have a lot of possibility. And I think that this is going to be of a great importance also in other trauma. Now, you know, our neurosurgeons are very good and with the intervention radiology to make spinal arteriography. And in the case of spinal trauma, they are able also to make embolization of very small vessels of our spinal doors and resolve the issue. So now let's move to the last but very important topic, that is acute gastrointestinal bleeding. I'm sure you are fighting every day with a lot of geriatric people coming in, taking anticoagulants, even decumarol, or new anticoagulants that have a lot of bleeding, especially if they take decumarol because they are able to control INR. So there is a very important, again, the need for the emergency physician to assess the hemodynamic instability and then immediately to perform an upper endoscopy. If the endoscopy is negative, you can go to check the colonoscopy, but if it is not possible to be prepared because you need colonoscopy, you need preparation, that you really, then you can go immediately for angiography. That is really something that emphasizes the need to have angiography area where you can do a lot of important setting decision making. Now, what about embolization? I am sure this has been, during the last 10 years, the revolution in stopping bleeding. And you can see from these data coming from registry, you can see that in trauma, the overall success of embolization is around 100%. Amazing. Amazing. You can solve the issue in many trauma, and also in the case of gastrointestinal bleeding, both from upper or lower sides of the enterical system, you can have embolization that are going to save lives. So it's not only a problem of hemorrhagic situation, but also of ischemic. Acute mesenteric ischemia is another important situation where, again, starting with the clinical suspicion, you are going to look about the possibility to have acute mesenteric ischemia and then to do CT scan and angiography. And also, in this case, you can have arterial thrombus that you can find, and then you can open the vessel. So I think it's very, very important to make important decision where to move or not from non-invasive clinical assessment to angiography. It seems to me there is a lot of room to improve and to need of angiography in acute setting. Let's talk about the contraindications. The last 2 minutes of my talk, I will address this important situation. Let me tell you that there are not really many contraindications in the case of need to perform angiography. You just need to make sure the blood pressure is quite controlled. You don't want to make sure that there is a renal insufficiency, so that the iodide contrast material is not going to deteriorate the damage, the function of the kidney. But thanks to the new quality of a new product, this issue is going to be very low. So in the future, my friends, we are going to have a lot of people, especially because life expectancy is worldwide increasing. And for the reason of that, we should, and also geriatric people, they have a lot of bleeding. We should really think about to increase our angiography performance into the emergency room. And these are my conclusions. After an initial clinical non-invasive technology evaluation, I put this in red, because it's the starting point. Please don't go immediately to angiography unless you have not made clinical judgment. In any case, it represents angiography a cornerstone in various clinical situations in the emergency department. It is also important because you are going to reduce the time of saving life and in hospital length of stay, so you can also save a cost. And in the future, I think it's very important that we are going to increase working together in the skills of angiography. But what do we need? We need research, data publishing, because like this consensus statement on academic emergency medicine pointed out a couple of years ago, in order to optimizing emergency department, diagnostic imaging has the potential to improve the quality, safety, and outcome in the emergency department. Because also don't forget the radiation are potentially dangerous for your patients. You really want to vote for the right patient, and we need the data. So my final auspice will be to produce more data in this setting. And thank you again for giving my talk. So just in the last 20 seconds, how many of you now are happy to have an angiography service next day in your emergency department? Yeah, I think it's increasing. I was expecting more, but that's okay. It's coming from 15% to 30%. Not bad, actually, without our auspicious. So, in any way, if you want really to contribute to our research, please come to Edinburgh or this biomarket, but last but not least, in San Diego, where we are working in implementing the geriatric emergency medicine, where I think angiography should be a big value. Thank you very much for your attention.
Thank you, Dr. De Soma. That was fantastic. At this time, are there any questions? I have a question for you.
Good.
That was a fantastic review of all the ways that we can use angiography in the emergency department in acute setting. It's not only diagnostic, but it's therapeutic as well. Do you see angiography at some point replacing the need for surgeons or surgery?
That is really the most important question. And I think, yes, this is the way we have to go, together, to produce evidence. If you saw last slides, I was making the evidence that we have to compare the value in any kind of innovations in emergency department that are two objective, patient outcome and cost related. So if we are going, as you said, to demonstrate that we can reduce surgeon length of stay and mortality due to therapeutic angiography, we are going to get the goal. And this is possible only with emergency physician skills in this topic.
Now, how many people want angiography in their emergency department?
I want. Thank you.
Okay, I want to invite with my pleasure. He is chairman of from Stanford University, chairman of Emergency Medicine Department, and he's very popular in Turkey, if you remember from last Congress. And I think he has very excellent textbook of emergency medicine in United States. He will talk about retrograde intubation. Mr. Mahadevan, with my pleasure.
Good afternoon, everyone. How are you? Good, good. It's great to be here. Instead of retrograde intubation, I spoke with Dr. Chander about talking about video laryngoscopy, so I'm going to focus on that today. And first, oops. Sorry. Okay. Just want to show you where I'm from. I'm from Stanford University, which is in the United States in California. So yesterday, approximately yesterday, 24 hours ago, my wife and I were there at that star right here. And now we're obviously in beautiful Antalya. And I just want to say this is my 5th visit to Turkey and love it here. I've been to Istanbul, Kayseri, Izmir, Konya, Çatalhöyük, and now this is my 2nd visit to Antalya, and I had the pleasure of attending a prior Congress, also getting to sing on stage. Hopefully I don't do that today and scare everyone away, and spend time with Bashar, which is always fantastic. In my talk today on video laryngoscopy, I'm going to define what it is. I'm going to talk about the different classes, the different kinds of video laryngoscopes, the advantages and disadvantages of this new device, and then most importantly, the current literature about video laryngoscopy and how it's maybe taking over how we approach airways. Very quickly, show of hands, how many of you are using video laryngoscopes in your department? Okay, fantastic. So quickly, with regards to the definition, video laryngoscopy is indirect laryngoscopy, which means you're not looking directly at the cords, that you're using a digital device, a digital laryngoscope, to show you the vocal cords in the glottis instead of line of sight. And generally, for what we need them for, acute intubations, we're inserting these devices intraorally. And why would we need to do this? Well, our goal is to see the glottis, and that hopefully will help us improve our success with intubation. And ultimately, we want fewer failed intubations. Obviously, we want to reduce our failure rate. So there are 3 big classes of video laryngoscopes. The first is the channeled video laryngoscope, where the endotracheal tube is part of the device or is inserted into the device, and this matches the anatomic curve of your pharynx and allows you to direct it towards the larynx. But unlike the other approaches where you are manipulating the endotracheal tube separately, this is all one device. So want to adjust where the endotracheal tube is, you have to adjust the device. And so the other issue with this, as you can see, is it's bulkier. It's larger than some of the other devices. And so if you have someone with a small mouth, it may be difficult to insert it. The next device I want to describe is something called a Macintosh-style video laryngoscope, where the technique is similar to what we're doing with direct laryngoscopy. And in fact, you could either use the video or do direct laryngoscopy. And for this reason, since everyone in the room can see what's going on and you can give advice, it's great for teaching and training institutions. And then finally, the GlideScope or GlideScope-like devices are acute angle blade video laryngoscopes, where they're really good at showing you the very anterior structures, but if it fails for whatever reason, you cannot convert to direct laryngoscopy where you can see the cord. So let's take a look at this. A GlideScope-like device inserted into the pharynx, and then you're looking at the monitor, you're looking at the screen when you're inserting the endotracheal tube, and so you're looking at the monitor but performing the function in the patient's pharynx. So what are the advantages of this approach, video laryngoscopy? Well, first of all, we always struggle when we're doing direct laryngoscopy to line these three axes. There's the oral axis, the pharyngeal axis, and the laryngeal axis. And if you look at this diagram, what you can see is that it's impossible for us to see like this. We have that line of sight. And so what we do is we try and get the patient into the sniffing position, as you can see here, and then by using the direct laryngoscopy and just raising their soft tissues, we achieve line of sight. And sometimes it can be very difficult, as you know, to see the glottis. And especially in patients like this. This is a trauma victim where you're not allowed to get the patient into the sniffing position because you're keeping them in the neutral position. And that makes it very difficult to align these axes. And in this particular case, the patient couldn't be intubated with the video or with the direct laryngoscopy. The other advantage in trauma patients specifically is the video laryngoscope can be inserted and manipulated in a way where you don't have to move the patient's head and potentially cause injury. Here's an example of a patient with an inferior anterior C2 fracture, but if we look at their cervical alignment, it's normal. So the spinal cord at this point is doing just fine. But what happens when you try to intubate the patient and you put them in the sniffing position? As you can see, this patient has a complete disruption of the ligaments holding the vertebral column together, and now the bones have moved and impacted potentially the area where the spinal cord is. So the last thing that we want to do is move the patient's vertebral column and potentially cause injury, which could happen in theory with direct laryngoscopy. And then finally, we're looking at a very narrow, small area and trying to insert an endotracheal tube through that area. Well, what if we were able to enlarge it, make it easier to see? And also, more importantly, as a teaching physician, that not only I could see what was going on, but everybody in the room could have confidence that this was being done properly or that we could assist. So those are the advantages of video laryngoscopy. What are some disadvantages? Well, if there's secretions or blood and it gets on the end of the scope, potentially you wouldn't be able to see. Or if the device fails for some reason and that's the only way, that might be an issue. There are a lot of different kinds of devices, so you have to be familiar with all of them, and we're not sure which ones really are the best. And there's no real evidence to tell us this is the best one at this time. And the technique for insertion is different than what we're used to. And it may be more challenging, just in the same way that if I play video games with my son, he's going to beat me every time because I'm not used to playing video games. Learning how to do a new approach may be challenging because you're not doing it under direct visualization. You're holding the device and then trying to look at a screen and perform the technique. And a number of studies have shown that when you're doing it indirectly, it can be more challenging. So now let's go over 5 important studies that might change the way that you think about video laryngoscopy as part of emergency medicine. And the first one to bring a lot of sort of attention to this was this systematic review, Cochrane review, that was done in 2016. This Cochrane review wasn't specifically focused on emergency physicians or critical care physicians, but looking in general at comparing direct laryngoscopy to video laryngoscopy. So they looked at a lot of studies, 64, 7,000 plus adult patients, but again, mostly in the operating theater and not in emergency settings. They compared different kinds of video laryngoscopy to direct laryngoscopy using a Mac blade. And here are the primary findings of the study. There were fewer failed intubations with video laryngoscopy, and this was statistically significant. When dealing with difficult airways, there were fewer failed intubations with video laryngoscopy. And then when they compared the incidence of hypoxemia, it was similar between the two. So, major headlines, bottom line from this large Cochrane review: fewer failed intubations overall, fewer failed intubations when dealing with difficult airways. Next, we decided, since that was a focus on all comers and primarily the operating rooms or operating theaters, what about for those of us that practice outside of the operating room? Well, this systematic review and meta-analysis looked just at those places. So this was 32 studies with over 15,000 intubations. And you can see that there were about 6,300 video intubations and 8,700 direct laryngoscopic intubations. And these studies were outside of the operating theater, outside of the operating room. So they were in the pre-hospital setting. They were in the ICU. They were in the emergency department, places that we practice. And again, they used different kinds of video laryngoscopes as opposed to just one kind, and multiple kinds of providers. So there were beginners, there were experts, there were paramedics, there were emergency physicians, there were ICU doctors. So a whole mix of different kinds of providers. And what they were interested in is how often do you succeed intubating the patient the first time that you try. So let's take a look and see what they found. With regards to first pass intubation, there was no overall difference in this study between video laryngoscopy and direct laryngoscopy. However, if you were in the ICU, video laryngoscopes were better, but if you were in the emergency department or pre-hospital area, they were similar. What about the glide scope, which is one kind of video laryngoscope, and direct laryngoscopy? Well, they were similar. But when the CMAC, a specific kind of video laryngoscope that allows both direct and indirect laryngoscopy, was compared to direct laryngoscopy, it was better in terms of getting that first pass intubation. If you were a novice or a trainee, video laryngoscopes were better. But if you were experienced or a paramedic, it was the same. And then with video laryngoscopy, there were fewer esophageal intubations and more arterial hypotension. So what are the big takeaways from this study of non-operating theater, of emergency